Okay, for the last part of this module, we're going to talk about disorders of the vestibular and visual systems. So in either one of these two systems, the disorders can affect receptors, they can affect cranial nerves, brainstem nuclei, because that's where the cranial nerves come from, tracts within the central nervous system, or the associated cortical areas. So the complete lesion that affects receptors or cranial nerves dedicated to that system will produce a total ipsilateral loss of sensory input for that system. So if you had a lesion on the vestibular nerve, that's a complete lesion, it's not an incomplete, just like with the spinal cord injuries we talk about complete and incomplete. You're going to get total ipsilateral loss of sensory input for that system. I worked with a gentleman one time who had a vestibular tumor, and he had total ipsilateral loss of the vestibular input from the side that the tumor was on. And as you can imagine, his balance was quite challenged, and we worked a lot on that. He had some good return from therapy, but he's never going to get it all back in terms of balance. And part of what we did is worked on getting him with the appropriate assistive devices. And for him, he was a pretty active guy before he started having problems with this. He was a guy in his 70s, and he did a lot of hiking and all this other stuff. So we went with bilateral trekking poles for an assistive device because that was more appropriate for the type of activities that he did. So usually when you're working with someone on assistive devices, you want to use the least restrictive assistive device that is most appropriate for that person. So it's going to be different for everybody. So a complete lesion in the retina or the optic nerve causes ipsilateral blindness in the visual system. So just on that side, again with the complete lesion. And we'll talk more about visual disturbances. We'll talk about some specific vestibular ones, then we'll talk about specific visual. So vertigo is an illusion of motion. It's the most common symptom of a vestibular disorder. You will hear people say it feels like the room is spinning, it feels like the room is rocking, it feels like I'm on a boat, that kind of thing. Those are a lot of times symptoms of vestibular disorders, and that is a common symptom. So we will talk for the assignment for this week. I'm going to have you, there's an objective measure that we have patients fill out that's called the Dizziness Handicap Inventory. It's part of a vestibular evaluation. And what it does is it asks people functional questions like, do you have trouble looking up, or something like that? And they just say yes or no, and there's a score that's associated with it. And you can determine their level of impairment based on their vestibular disorder by their answers to this Dizziness Handicap Inventory. Each one of the questions on the Dizziness Handicap Inventory corresponds to a particular type of effect in the vestibular system. So that's what we'll talk about in the assignment. It's kind of fun to associate those functional things with what is happening in the person's vestibular system. So vertigo occurs with both peripheral and central disorders. So it arises from a disturbance of spatial orientation in the vestibular cortex. So if someone has vertigo, you need more information to determine whether it's a peripheral or central disorder. So vestibular disorders can cause pathologic nystagmus, and nystagmus is where the head moves and the eyeballs sort of bob back and forth. So you see their pupils move back and forth. It's fatigable, meaning that it diminishes over time, and it habituates in most peripheral disorders, but doesn't fatigue or habituate in central disorders. That is the way you can, the nystagmus is the way that you can differentiate between a peripheral and a central disorder. So a lot of when we talked way back in chapter 4, when we talked about habituation, a lot of the treatment for vestibular disorders is to habituate to those movements that are causing you the disturbance. So if you have a peripheral vestibular disorder, habituation will work. If you have a central disorder, habituation will not work. So that is one of the ways that they can tell. So we're going to talk about some particular vestibular disorders. Usually they cause recurring periods of vertigo, often nausea, for the peripheral ones. Peripheral symptoms tend to have more severe nausea than central. And nystagmus always accompanies peripheral vertigo. There's an interesting diagnostic tool that the vestibular specialists I work with use. They're these infrared goggles. They put them on the person, and it shows it displays on the screen, on the computer screen, a close-up of their pupils, so you can detect very small nystagmus that you wouldn't be able to see visually without the aid of those goggles. When someone's got big nystagmus, you can see it, but when it's really small, a lot of times you need an instrument to detect that. But because auditory and vestibular structures are in close proximity to the inner ear, you often get, with peripheral disorders, diminished hearing or tinnitus, which is the ringing in the ears. So often those are symptoms associated with the peripheral vestibular disorders. So the ones that you see most commonly are BPPV, benign paroxysmal positional vertigo. That's the one where your otoliths get loose and they're messing things up in there. Vestibular neuritis, which is inflammation of the vestibular nerve, and it can often be caused by a virus or a bacterial infection. So vestibular neuritis is often an infection. In 2002, I had vestibular neuritis, and I had about 8 weeks of vertigo. It was hell. I hated it. It felt like the room was rocking. I couldn't drive. I had trouble doing my job, even though I could still do it, but I had to be really careful not to lean back or look up. I would lose my balance. I limited my workouts to strictly mat workouts. I did mat, Pilates, and yoga the whole 8 weeks. And after feeling sorry for myself for a little while. And so vestibular neuritis can have a big effect. The good thing about it is it goes away. BPPV can be treated really easily in an outpatient setting. Ménière disease is a degeneration of the vestibular nerve, and it does not go away. You can get traumatic injuries of vestibular disorders, and there's another one called perilimb fistula, which we'll talk about a little bit. But really, all I want you to know for the test is BPPV, vestibular neuritis, and Ménière's disease. So BPPV, it's one of the disorders that cause vertigo and nystagmus. It's benign, which means it's not malignant. Paroxysmal, sudden onset. Positional, head position is the provoking stimulus. So that's where the name comes from. So a rapid change in head position will result in vertigo and nystagmus, and it'll subside in less than 2 minutes, even if you keep in the provoking head position. So that's the nice thing about it, is it comes on and then it subsides within 2 minutes. So it's not vertigo that sticks with you forever. A lot of times the activities that provoke it are getting in and out of bed, so you're going from horizontal to vertical, bending over to look under a bed, so you have that big head movement, reaching up to get something off a high shelf. That was one of my symptoms with vestibular neuritis, or turning over in bed, that rolling. So when you think of the semicircular canals and all the different ways they go, a lot of those are affected. Getting in and out of bed, you're hitting one of them. Bending over, you're hitting another one of them. Reaching up, you're hitting one. So, and turning over, one of the semicircular canals. So BPPV is caused by displacement of the otoconia from the macula into a semicircular canal. So those otoconia are rolling around in your semicircular canals as you get in and out of bed, or reach, bend over to reach under the bed, or look up high, or turn it over. And so it's stimulating those the endolymph in the semicircular canal, giving you some bad input, basically. And so they can be displaced the displacement of the otoconia can be caused by trauma or infection that affects the vestibular apparatus, although sometimes it occurs spontaneously. So it's treated really easily. There are some, they call them the canalith repositioning techniques, and there's a video in the module that shows them. They're exercises, and basically one of them, you lie on whatever side is affected. The therapist decides what side you're going to lie on. You quickly turn your head and sit up real fast. So you actually you're moving those otoconia into their proper place. So there are several different things. There's the Epley's maneuver. There's the Brandt dart-off maneuver. So depending on where, what semicircular canals are affected, and the therapist will figure that out in their evaluation by the symptoms. They decide which technique they're going to use to reposition those otoconia, and BPPV is one of those ones where it can be cured in one PT session. Sometimes people need two, but most of the time one is all they need. So it's pretty cool. Vestibular neuritis, it's a inflammation of the vestibular nerve, usually caused by a virus. So disequilibrium, spontaneous nystagmus, nausea, and severe vertigo for up to 3 days. And you don't have any hearing loss. You have decreased or absent response on the involved side to the caloric testing. And during the acute phase, sometimes they use anti-nausea medication. There's a couple of anti-vertigo medications that they'll use, and they will try to, the anti-nausea they'll use to try to suppress vomiting. I'm really glad when I had vestibular neuritis that I did not have any vomiting or nausea. That would have been horrible. The vertigo was bad enough just in and of itself. I was a little bit disappointed when I went to my primary care physician about it. They were kind of the diagnosis they gave me, they said, well, this might never go away. I mean, that wasn't a really nice thing to hear, and thank God it went away in a couple of months, but they weren't very encouraging. But I guess they don't like to get your hopes up, but the idea of that never going away would have been really bad. So Meniere's disease, it causes a sensation of fullness in the ear, that tinnitus, it's the ringing in the ear, severe acute vertigo, nausea and vomiting, and hearing loss. And hearing loss is one of the most debilitating things about Meniere's disease. It's associated with abnormal fluid pressure in the inner ear, and they don't know what causes it. So it's idiopathic. So a lot of times they'll use the vertigo drugs during acute attacks, and sometimes they surgically sever the vestibular nerve if people are having extreme problems to relieve the vertigo symptoms. But it's progressive, and it's besides severing the vestibular nerve, which obviously creates its own problems. There's not really much of a treatment for it besides just treating the symptoms. So traumatic injuries can cause concussion of the inner ear. It can fracture bone surrounding the vestibular apparatus and nerve, and cause pressure changes in the inner ear, which affects the vestibular apparatus. So any of those injuries can compromise vestibular function just because you're changing things in the area where it lives, the vestibular apparatus. So the perilymph is the fluid in the space between the bone and the labyrinth in the inner ear. And so a fistula occurs when there's a fistula is usually an opening where there isn't supposed to be an opening. So you get an opening between the middle and inner ear, and it allows the perilymph to leak from the inner ear to the middle ear, and it produces hearing loss and tinnitus and vertigo. So a lot of times they're secondary to trauma, and they actually put a scope in there. They do an incision and scope to find the perilymph fistula. So that's not one that you usually see in physical therapy because it's a surgical intervention. So the ones that you usually see in PT are the vestibular neuritis and the BPPV. So you can also have any other, you can have nerve lesions, just like any other part of the body. When you have bilateral lesions of the vestibular nerve, they interfere with reflexive eye movement because that vestibular ocular reflex isn't happening. And the initial symptom or complaint that people have is let me see if I can say it, oscillopsia, which means the sensation of visual objects bouncing around when the head is moving. So that's what I was saying. That's that cinematographer effect, where the world is bouncing side to side as a person walks or moves normally, because the normal reflexive adjustments for head movement are decreased, and so we're not able to stabilize our visual field anymore. So some of these, and with some of the vestibular symptoms over time, the nervous system can adapt to the change, and people report having less difficulty. So a lot of times that can happen with a lot of vestibular disorders. People just adapt to them, which is nice. But other than that, there's not really a treatment for that. So with central vestibular disorders, they result from damage to the vestibular nuclei or the connections to the brain. And a lot of times, interestingly enough, the central disorders produce milder symptoms than peripheral disorders. So a lot of times they're ischemia or tumors in the brainstem or cerebellar region, or the couple other things that they mentioned there. So a lot of times with those things, you're having worse symptoms than your vestibular disorders, and they're kind of milder than the peripheral disorders, and the treatment is going to vary depending on what is causing it. So after someone's had a stroke that's affected the brainstem and the cerebellar region, there's a lot to deal with before you even get to addressing the vestibular disorders. Migraine headaches can cause vestibular dysfunction. And a lot of times it's a diagnosis of elimination, where it just doesn't fit other syndromes. It's just not they can't figure out what's going on, and maybe there's a family history of it, and it's sort of an isolated symptom that doesn't happen at the same time as the headache. So it's someone who's prone to migraine headaches, and then they have vestibular function at some other time when they're not having a headache. So those ones go a long time without being diagnosed because they're so unusual. So there's a chart in the book of the central symptoms, and or basically it has a symptom and then whether or not it is in the peripheral or the central nervous system. So a lot like we did with the spinal cord case studies, a lot of times when they're doing diagnosis, they're comparing symptoms and they're trying to determine whether it's peripheral or central by looking at something like this, where you're comparing the different symptoms. So nystagmus, it's almost always present in a peripheral vestibular disorder. It's typically unidirectional and not vertical, and it you can habituate to it. Central nervous system, it can be a lot of different directions, and you can't habituate to it. You just never habituate to it. So you can just look down the list, and it's interesting that just one of the ways, obviously as PTAs we're not doing diagnosis, but it's interesting to see how these different things are diagnosed. So with unilateral vestibular loss, it causes problems with posture, eye movement control, and nausea. So signals from the damaged side aren't correctly balanced with signals from the intact side in that usual reciprocal balance. Excuse me. So a peripheral lesion that interferes with otolithic function on one side causes imbalance because the information from the normal side isn't balanced by information from the lesion side. So the vestibular system really works, the two sides work together, and so if you have a unilateral vestibular loss, it can really mess up. Even though you have normal input from one side, you're just not getting the kind of input that the vestibular system needs. Okay, so there's a little diagram in the book where they talk about the ocular tilt reaction, where one eye goes up and one eye goes down. We're not really going to go much over that. So when you get bilateral loss of otolith input, it eliminates the person's internal sense of gravity. So they need visual and proprioceptive cues for spatial orientation. So obviously that messes you up when you're walking in the dark or walking on uneven surfaces. So if you don't have a symmetry of the vestibular information, you don't have any vertigo. So with bilateral vestibular loss, vertigo is not usually one of the symptoms. It's usually a balance and postural issues. So there's a little chart of different things that might cause. There's a list of peripheral vestibular disorders and then central vestibular disorders, which is kind of interesting. So when we start talking about the disorders of the visual system, we're really going to talk about two of them, even though I have listed some other ones in the PowerPoint. So anywhere along the pathway, you can have a lesion, and because that visual cortico pathway is so convoluted compared to other pathways in our body, half of it crosses over, half of it doesn't. The visual losses really vary according to the location of the lesion, and there's some good pictures in the book showing different lesions and what kind of losses result from them. So usually they describe visual losses by referring to the visual field deficit. So bitemporal hemianopsia. So if we break the word hemianopsia down, opsia is vision, sight, an is no, hemi is half. So half of your visual field you can't see, if that makes sense. So in bitemporal, a lesion of the optic chiasm interrupts fibers from the nasal half of each retina, causing loss of information in both temporal visual fields. Okay. In homonymous hemianopsia, a lot of times this happens in people with hemiplegia, so after a stroke, or sometimes people with CP. I have worked with a couple people with brain injuries who have homonymous hemianopsia. It can cause visual neglect where one side of the visual field is not attended to. It's caused by a complete lesion that interrupts tracks posterior to the optic chiasm. So it produces loss of vision from the contralateral visual field of both eyes. So for example, say the lesion was posterior to the chiasm on the right side, you would lose the left half of the left eye and the left half of the right eye. Okay, so there's some videos in the module that show what a visual field of a person with homonymous hemianopsia looks like, and it's really interesting. One side's blurry, one side's not, and you can see how it can result in neglect. And we'll talk more about neglect when we're talking about the cerebrum chapter, where it comes in, but it's like people can't see on that side. It's really a very interesting disorder. So there's also some information about tests and examination of vestibular function in the PowerPoint. Mostly I included those because they were in the book. And then there's some information about vestibular rehab. In the module, there's some videos with some of the different vestibular exercises, and that is something that, of course, as PTAs, we're not going to be doing testing and diagnosis ordinarily. We might retest something for a PT, but a lot of times we will be doing rehabilitation. We will be teaching people the Epley maneuver, teaching people the Brandt-Dardoff maneuver, that sort of thing. And this is certainly something that you're not expected to know as a new grad, but it's something that you can get continuing ed in. It's a really interesting area of rehab if you're at all interested in it. I would recommend it because it's a great area where you can really help people in a very profound way. So, ordinarily, rehabilitation doesn't directly affect central dysfunctions, and it's pretty much ineffective for Meniere's disease. So, rehabilitation is effective for BPPV, unilateral vestibular loss or dysfunction, and bilateral vestibular loss, and central vestibular disorders that benefit from movement retraining. So there are some things where we're just never going to get patients in that because rehabilitation is not effective for those things. Most of the time, vestibular rehabilitation is exercises that promote movement retraining, habituation, or substitution to improved function. So movement retraining is where you practice and modify movements. Makes sense, right? Habituation is where you expose your patient to positions or movements that produce symptoms, followed by relaxation until the symptoms abate. And so, for example, one of the ones that you do for BPPV, the one I was talking about where you're lying on your side and you turn your head and sit up really fast, then you sit and rest and relax until the symptoms subside, which is usually in 2 minutes or less. And then you do it again. So you continually provoke the symptoms, and the time it takes you to recover from them usually gets shorter and shorter until eventually you are unable to provoke the symptoms using that movement, and then you've habituated to it, which is great. That's the result that you want to get. So substitution is where you use other sensory inputs or motor responses to using predictive or anticipatory strategies. So you're substituting another movement or using other sensory input to do what you want to do, basically. And that can be very effective for people that aren't going to get something back. So when you have, like for the bilateral vestibular loss and the unilateral vestibular loss, you have to substitute the movements because you're not going to get that back. Okay, so we're going to wrap this up. And then the last group of lectures will be about the cerebrum and the support systems, and then we're going to be done with the new information in this class, which is amazing.